Hello and welcome to Unleashed, the show that explores how to thrive as an independent professional. I'm your host, Will Bachman, and I am so excited to be here today with Mary Cummins, former partner at BCG and Deloitte, who now is an independent consultant running Certus Advisors. Certus is Latin for purposeful. Mary, welcome to the show.
Hi, Will. It's great to be here.
So, Mary, we got a lot to talk about today. I know that you cover the healthcare and life sciences industries. I want to start with an area that I'd like to learn more about. So, what is value-based care?
So, put simply, Will, value-based care means paying for the value of the healthcare that you're providing to somebody instead of paying for the service provided, which is what happens today in the U.S., where the funding of care is on a fee-for-service basis. And so what you'll hear is people talking about the shift from volume to value, which is where payers, whether they're commercial insurers or government payers like Medicare and Medicaid, are shifting financial risk to the people providing care, which means hospitals and doctors' offices and so on.
So I imagine this is kind of is non-trivial, because we could say, let's say that someone gets, I don't know, surgery to remove a cancer, right? So the surgeon might do a totally great job, but sometimes even if you do a great job, the person is still going to die, right? Unfortunately. So it's like the outcomes could be they do a crummy job and the person dies, or they do a crummy job and maybe the person actually does okay, still they live, or they do a really great job and the person dies, or they do a great job, person lives. So it's like hard to know really what the value is. Is it just based on outcomes, or how do you actually measure value when even if you are doing, providing great care for someone, they still might have a bad outcome, like hospice. Right? At hospice, everybody goes into that with sort of, the end in mind. But so like, how do you measure value?
Yeah, so I think you asked a lot of questions in there, but
a barrage, a machine gun of questions.
You can measure it in terms of clinical outcomes. You can measure it in terms of patient satisfaction and the patient experience, and you can measure it in terms of economic outcomes. And the mantra, Will, that I think best sort of encapsulates what value-based care looks like is it's the right care to the right patient at the right time, at the right site of care, by the right care provider, and at the right price. So there's an awful lot of rights in there, to your point about this is non-trivial. And so at the moment, if you're in a fee-for-service world, you may have all sorts of situations of waste where people are being compensated on the number of tests they perform, and the patient wants the test, the patient isn't bearing the cost of the test, and the physician doesn't necessarily want to argue with the patient about why they should have it, all the way through to more extreme examples where you have people being paid and who are, where the outcomes are poor. And just to dig into a bit about why we're talking about this and why it's so important. And by the way, I apologize to folks listening. I'm going to be pretty U.S.-centric in how I talk about it today. But we started talking about this a lot more after the Affordable Care Act passed in 2010, and there have been a number of other payment reforms since, trying to shift the system from this volume to value. The reason why is because the U.S. is in a pretty lousy position, frankly, when it comes to healthcare spending. And so you have very high costs of healthcare, and you have trends on things like an aging population and increasing prevalence of chronic diseases that keep that spending trend going up. And so I'm sure many people have seen the charts about the spend per capita and the percent of GDP going up. And there is a lot of variability in the outcomes. And so you'll see lots of charts that show the U.S. against countries in terms of some of those clinical outcomes I was talking about, against the spend per capita as a way of looking at value. And then you can look at a much more micro level. So, for example, if you're having a hip operation, and you can look at costs and quality of outcomes in all sorts of different parts of the country, and there's just not the correlation that you would expect.
Yeah. So let's talk a little bit about, I mean, I can see some reasons why it would be difficult to make this shift. Because even if everyone could agree and sit around the table and agree, yes, that would make a lot more sense to pay for value. Just the way structures are created and embedded and the way payment systems are set up. And it can be kind of difficult to get from here to there, to sort of change the wheels on the bus while you're in motion, or to dismantle these structures and to set up new regimes. So talk to us a little bit about kind of pre-COVID. Just let's take COVID out of the situation for a minute. Pre-COVID, what were some of the things that were happening? Or maybe actually I'm sorry, changing my question. Let's dial it back to even before value-based care. Just give us a snapshot of the landscape of, in the U.S., how is the pay for service typically structured? And then when did conversations start happening around, let's do value-based care? And what's some of the history behind this of what are some of the attempts that were been happening?
So I'm not going to go all the way back in history. Some of us remember healthcare reform in the 90s and early capitation and the emergence of some health management organizations, the HMOs, and big backlash against those. Let's not go quite that far back, but the landscape started changing, say, after the Affordable Care Act in 2010, where instead of being completely paid fee-for-service by Medicare and Medicaid, CMS really took the lead in driving this transition to value-based care. And so they set up a number of different payment models, which are called APMs, or alternative payment models, that essentially have increasing levels of risk that the provider takes on. And so this is between CMS, the government, and a hospital or a health system or a physician practice. And if you don't mind, I'll just tick through a couple of them so you get a flavor. The simplest are shared saving models, and you might hear them called pay-per-performance or patient-centered medical home. And these ones are where it's upside only. So you as a provider get paid on a fee-for-service basis until the end of the fiscal year, and then there's a reconciliation, and they take a look at some predefined cost and quality metrics. And if you've saved on that utilization and the spend, you get to keep a share of the money. So it's upside only. But if you don't meet the goals, there's no downside risk. And so that's the easiest one to transition to, but it doesn't necessarily move the needle very much in terms of changing outcomes. And then there's ones that are called bundled payments, and this is where you get a predetermined amount for a particular defined clinical episode. And so this might be something like a hip replacement or a CABG, a coronary artery bypass graft. And so you know what you're coming in with, you know what's going to happen, you know the post-operative procedures, you know roughly how long it's meant to take for a particular severity of patient, and you will get reimbursed a particular amount for that to the provider. And then the provider, who you're paying, has to sort out the care all that way through the diagnosis and the procedure and the rehab and pay everybody involved out of that set fee. And so that's got upside and downside financial risk potential to the provider. And then there's something called shared risk, which is a bit like the shared savings, but with some downside risk. And then finally, there's global capitation. And that's where the provider is fully at risk, and this is where you hear about a per member per month. So I get paid X dollars a month to take care of Will's health, and I have to coordinate care for all of the different things that Will needs within that amount of money.
Okay. So what were some things that were going on after the Affordable Care Act passed to transition to these different models? Is it kind of a state by state thing, or are there just some experiments or some pilots going on? Like what was happening where to move to these models?
Yeah, so this is interesting. So one thing to watch for as the new administration takes hold is what CMMI is going to do. So CMMI is the Center for Medicare and Medicaid Innovation, sits within CMS. And they have been driving these demonstration pilots and models in all sorts of different ways to experiment to find out what really works and can then become part of Medicare and Medicaid. And so you'll see them in different disease areas. So some of the things I've talked about, like a cabbage-related one. They've been doing things in renal dialysis for end-stage kidney disease. There's a new one that's being worked on in radiation oncology, and they've been doing these as pilots. And so different places of the country are opting in and out of them, but also there's been some where they tried making it a mandatory rollout. And then pulled back a bit from that. So CMS has been driving that and experimenting and taking ideas from providers on what are things to try and tackle. And at the same time, there's been some movement also by non-government players. And so, again, going back in history a little bit, back in 2014, there was something formed called the Healthcare Transformation Task Force. And this is a bunch of payers and providers and patient advocates and so on who wanted to act as a private sector driver of the transformation. And they actually made a commitment to have 75% of their respective businesses in value-based payment arrangements by 2020. And so, we're now in 2021, and I'm waiting to see the data on that. We've seen some shift away from fee-for-service, but, honestly, Will, every year it seems like that really comprehensive shift is some way off. And, to your point, the truth is this is really, really hard, and that is true before COVID hit.
So is this primarily about the government-run healthcare programs like that CMS does, or are there also commercial pay where if you have a regular employer and they're providing you healthcare coverage, are some of those experimenting with value-based care?
So a lot of the models are being driven by the government and then spilling over into how the physicians and the providers operate. But if you think about it from the provider perspective, and this is one of the things that's very hard, you're operating in a split screen world where you have some contracts that may be at risk, you have some fee for service for patients coming in, you may even, if you're some of the leaders in this, you may even have tried contracting directly with an employer. So Cleveland Clinic was one of the people who did that early on for employers who would then send their employees for certain types of cardiac procedures to Cleveland Clinic, and they had agreed a bundled price on it. So it is quite a mix.
Okay.
One company, sorry, if I may.
No, go ahead.
So if you look at someone like Humana, who is a leading insurance company, a commercial insurance company, they are somebody who's been very aggressive on this, and you'll see them actually. They put out a report each year about what they're doing on value-based care, and they have a focus on getting some of their Medicare Advantage members into value-based arrangements, which are different from the ones that are being run through some of the Medicare models. So they're still Medicare patients, but they're in a commercial plan as opposed to the traditional Medicare programs.
Let's talk about it from the perspective of some different players in the market. So maybe we could start with healthcare providers. And for a hospital, how does this look for a hospital, and how do they need to change the way they manage the hospital? If I suppose,
Yeah.
and I suppose it's even more complicated because they might have some patients coming in who are
Yep.
traditional fee-for-service and some who are value-based care. So it might be even different if you were just 100% was all value-based care. You could operate in a coherent way. But like, how, if you're the CEO of a hospital system, like, what do you have to do differently with value-based care as some percentage of your patients?
Yeah, so being the head of a hospital system is never an easy job, and certainly not these days, but it is genuinely very complicated. And so you may be sitting there, and your first question is, should I be in a value-based care arrangement for any of my patients? And you may well think, yes, at some point I will need to be and I should be, but can I make that transition now? And the reason why it's hard is a couple of things. One is making the transition requires you to spend money on putting a bunch of things in place that I'm about to talk about, and hospitals, for the most part, are under a lot of financial pressure, and there's some Congressional Budget Office forecast, for example, and if you look at the average hospital profit margins, it's literally just a couple of percent today, and they're forecast to go negative 20 basis points within a couple of years. And so you're already under massive financial pressure, and you're trying to find cost reductions, and this requires investment. So that's one challenge for you. The second thing is, in terms of what you want to spend the money on, you have to figure out, in order to take on risk for care, you have to figure out the care coordination all along the continuum. And so not just inside your hospital or inside a hospital-owned clinic, but you may need all sorts of other care providers involved in treating that patient. So, to say rehab, for example, or different kinds of diagnostics. And you have to figure out how to understand, have those players in place that you may not own, have all the right technology so that you're capturing the right information and sharing it through these different institutions. And frankly, interoperability is a whole other topic that we could touch. You have to really understand the variability in care between different sites and between different providers so that you can think about the risk. And so that's a lot of analysis and redesign of care protocols and getting physicians information on time so that they can choose to do something differently and not just look at a post-mortem on old payer data after the fact. Then you have to figure out how to take on and manage financial risk, which is a very different set of skills for a hospital. And you have to think about some of the fundamental behavioral change for physicians in this that you have to navigate them through. So the hospitals are in a very tough place because their core business is still heads in beds, to put it bluntly. And that's why, from a hospital or a health provider perspective, you'll see some of the people who've been ahead on this People always will talk about Kaiser or Geisinger, where there's systems, and so you've got the hospital, but you've also got the health plan side of it, and there's both more experience of some of the capabilities I've talked about, but you've also got alignment of incentives internally.
So, what are some examples of how hospitals start operating differently or have to operate differently under value-based care? I imagine, like, there, some of the things might be that they'd have an incentive to start being pickier on what patients they take, potentially. Like if you're going to, compensate me on good outcomes, for example, I'm going to take patients that I think are the most likely to have good outcomes and maybe deny the other ones. And I guess I would also have to crack down on things that are truly wasteful and just not that useful, like tests that maybe we really don't need to do or something. I'd have to rethink the whole way I'm operating the business. Give me some examples of, because I'm just making it up, give me some real examples of how hospitals operate differently.
Sure. So if I'm a hospital-led accountable care organization, so I'm going at risk, the cherry picking on patients that you brought up, Will, is a real unintended consequence. Let's not tackle that one on this call. Let me talk about some of the things that they would do differently with good intentions. Because you could argue if you are assessing the risk of that population with high risk needs correctly, then you can still give them good care. You shouldn't just avoid them. But a couple of things you would do differently. You might actually order more tests of certain things, or you might order less. You might say, well, wait a minute, let's also, when you go home, we're going to give you some at-home patient monitoring equipment so that we can check on your progress outside the hospital walls. You might say, we're going to measure performance differently. And so here's a set of statistics that we're now going to be tracking, not just about your clinical outcomes, but about patient satisfaction and patient-reported metrics. And we're going to roll all of that up, and we're going to look at it at a provider, an individual physician level, and think about how we're seeing differences in quality by physician, or the fact that such and such a site of care they're getting much better outcomes for similar patients on their knee operations than this other site is. What are they doing differently in their care protocols, and how do we transfer best practices?
Yeah. What about the case where if I'm being compensated on the bundled amount, so when you walked through earlier through the different systems, so if I'm being paid, for example, on the cabbage, procedure, and let's say that I'm able to structure it so I'm actually making some money on the cabbage, then I say, great, I want as much cabbage as I can get. On the other hand, if there's a different payment scheme where I'm just being compensated on the overall health outcomes of the patients, or I'm just giving a fixed, fee per member per month, then I'm incented to avoid cabbages in the first place by getting people earlier to have healthier habits, to check in with their heart, to get earlier treatment on things, and avoid the cabbage in the first place, right? So am I off base there, or does some of the payment structure really affect where I would want to intervene?
I think the right answer there, Will, is yes. And in fact, this is something that the new director of CMMI has been going public about, talking about as she comes into the role, which is that some of these models may be somewhat overlapping, and so they're trying to figure out how to make sure that the models are coherent and work together as opposed to potentially working against each other. I will say though that it's still early enough in the process of adoption of this that you're not necessarily at a point where you're making trade-offs quite as directly as you said.
Let's talk about pharma companies a little bit. So how does the value-based care affect pharma companies?
Yeah, so for pharma companies, so this is where you might see people talking about VBC, but it's not value-based care, it's value-based contracting. When you see VBC for drug companies, so there's been a lot of discussion on this. There's a lot more talk than action. I think in the U.S. there's something like 23 publicly disclosed value-based contracts for drugs and biologics, and people think there's about 88 in total, but the details aren't public. What it plays out for a drug company is that instead of just saying, okay, this is how much it costs and I'll give you some volume-based rebating, you can have something like a warranty where if it doesn't work the way I said it was going to work, then I'm going to give you a rebate. Or you can have some that are really true outcomes based where it's an economic outcome or a clinical outcome. And so it's about sharing of risk. And so these are called risk sharing arrangements. And so for a drug company, you really need to think about what's the right patient populations that you want to go at risk for. How do you make sure the patient is adhering to the regimen so that you get the outcomes that you think your drug delivers? What time frame are you going to get those results in, both clinically and maybe some of the downstream value benefits and so on. And the person on the other end of the contract, so a payer, for example, and Humana and others of people who've done these, has to agree that there's enough value at stake here to go through all of the pain of actually setting up and administering these contracts. And so, why don't I just make it real? A couple of examples. So hepatitis C was an example where I guess it was, 2015, there was some first-in-class curative therapeutics. And so you take a relatively short course of the drugs, it's 8 to 16 weeks or so, and then you're cured. So, this is terrific, right? Great innovation, great value to patients, and you also avoid a bunch of the downstream healthcare costs to the system if your condition worsens and you get liver failure or transplants or worse. But you had a reasonably large population of all of the accumulated Hep C diagnosed individuals, including Medicaid folks. And so suddenly there's a big hit to state budgets. And so Gilead, which was one of the innovators of the drug manufacturers, announced some value-based contracts to help get it accepted and adopted and paid for. And what they're doing now, though, is with the Hep C market down, because you've essentially treated all those accumulated patients and you're just treating the newly diagnosed each year, plus there's more competition, the drug companies are looking more at what they call Netflix contracts. So it's a subscription type contract where you pay a lump sum and it's much, much easier to administer, and it locks in volume for the drug manufacturer. So they've moved away from that. There's the other example that's pretty hot at the moment. People are talking about pricing strategies for some of the high-cost personalized therapies. And so these are really exciting scientific innovations like next-gen cell and gene therapies, so CAR T therapies for different types of cancer patients, for example. But they can be very, very expensive, but they're for pretty small populations so far, and so we really haven't seen any of those announced yet.
What about some medical device companies? How does it affect those players?
Oh boy! So for medtech companies, it's even more painful if you can imagine it, because for medtech there's a lot of diversity of offerings, but let's stay away from things like imaging and molecular diagnostics and keep it simple for a device like an implantable cardiac pacemaker or a new hip implant. So you have all of the challenges I talked about with drug companies in terms of getting the right patient population and figuring out what metrics you're going to measure and getting agreement on what the baselines are and what the time frame is that might be way outside for the benefits to the patient or to other stakeholders versus the health system. But on top of all of that, you're not just swallowing a pill. You're having a surgical procedure, and there are all of these uncontrollable factors like the skill of the surgeon or whether he's having a bad day or the nursing care that you get to avoid infection. And so if you don't have the right outcomes and it's not what you expected and you're pretty sure it's not the implant but you think it's the surgeon, it's really, really hard for you as the medtech company to then go into conflict with the surgeon, who, by the way, traditionally has had a lot of say in whose physician preference implants get selected. So it's extra factor of complexity for medtech companies. And so you've seen a few examples, which again are sort of the rebates if it doesn't work, the warranty type things, and there's a couple of others, but it's again not very prevalent. Just to finish off that thought for a moment, Will, what I would say is that for medtech, there are all sorts of pressures about having a very compelling value proposition and having the right kinds of evidence to support it. And so that will only increase in necessity for the medtech companies, but without them necessarily having to go all the way to administering an outcomes-based contract.
Do you want to share any other, any experiments that are going on today, kind of across the whole range of value-based care?
Yeah, so it's always interesting to watch some of the early leaders. So, Geisinger, for example, which is this integrated health system in Pennsylvania, they've not only started thinking about what's worked in terms of managing value-based care, they also are doing things as it relates to getting their members to do genetic testing with them so they can get into earlier stage diagnosis and prevention. And part of why they do that is because they have actually a pretty stable member base in terms of people, not switching health plans every year. And so they have the trust for individual patients to let them see their genetic results, but also the incentives. So they're interesting to look at. I think, Humana I mentioned, United Health and Optum, they've been buying providers to essentially own more of the care continuum, and they're obviously investing a ton in analysis through Optum to try and make sure you can put all of this together. And then there's a couple of things that are in the news these days. So the CVS Aetna acquisition and the things that Amazon is doing with its own employee clinics and PillPack and so on. Those are things that I would describe as value agnostic plays. They are intended to make healthcare more effective for people, but they're not necessarily linked or contingent on value-based reimbursement for them to still have a good business proposition and make it work.
Yeah. Let's talk about your practice a little bit. What types of clients do you serve, and give me a couple examples of the projects that you do?
Sure. So it's quite a range, whether it's providers or payers or on the life sciences side. So one very interesting project I did, which the audience on this call who understands some of the strategy toolkit, was around dynamic strategic planning around scenarios in the middle of COVID for a Medicaid managed care player last year. So Medicaid managed care players right at the heart of uncertainty with everything from the pandemic and how care was materializing to all of the policy-related choices. So working to help develop strategy scenarios and support the strategic planning. A completely different example, working with a board chair of a specialty pharma company to help them think about where their next areas of growth were ahead of a strategic exit. I was just on a call today with a medtech company thinking about how they are diversifying and growing their portfolio and some of the choices they have. So a lot of interesting things out there.
Fantastic. So, Mary, for consultants that wanted to follow up with you and find out more about your practice or possibly reach out to you, where would you like to point them online?
Yeah, get in touch with me on LinkedIn, and I'm pretty easy to find, and that also has a link to my website on it, and you can also contact me through that.
Fantastic. Well, we will include those links in the show notes. Mary, thank you so much for joining today and helping me get a little bit smarter about value-based care.
You're welcome, Will. Thanks, and have a great day, everyone.